So I'm in practice in Cupertino. Kim and I work out of the same office in Cupertino. She's also in Stockton. I think I may have taken like one stitch out of Mr. Palmiato, so that's one for Dr. Lay. I did have a hand in that one. So just to kind of, there's been a few questions about what Graves is and what Hashimoto's is, and you could get a lot of molecular biologists and endocrinologists in here, and they could tell you in a lot of detail what's binding to what and what's going on. But in the end, there's just kind of a spectrum of autoimmune disease related to the thyroid, and it's not you asked I think you asked which is hypo and which is hyper. It can be a little bit of both. I mean, most of the time Graves is hyper, most of the time Hashimoto's is hypo, but they both can go through brief periods where they could be polar opposites. So we all know thyroid hormone's critical to running the physiology of our body, maintaining our mood, muscle, bone density, just everything. Too much of it puts us into a state where we're anxious, our heart races, we lose weight, gets us into a mental emotional state that's unfamiliar for us. We've obviously talked about that a lot tonight. But if anybody wanted to know sort of specifically what's going on, I mean, your own immune system creates an antibody that essentially fits perfectly into a receptor in the cells of your thyroid and causes it to produce thyroid hormone. Those same antibodies couple with other proteins and that sort of thing in your orbit, the muscles of your eyes and the fat, creating this hard fat that Dr. Cockrum had described earlier in these large hypertrophied muscles that cause difficulty with vision and double vision and impingement of your orbital or your optic nerve. So, so I just already talked about how these immune complexes here will couple together, cause fat to grow, cause other things called hyaluronic acids and other little proteins to grow out of control in the orbit. And it literally just causes the growth of these muscles, and the fat and everything will literally just compress the nerve, push the eye forward, put it on stretch. But it's not always as mechanical as that. Sometimes we do decompressions on you, and you still have inflammation of your optic nerve, and there's not really a good explanation why, other than we just have to keep treating you as best we can. Who has Graves here? Just about everybody in the room. So the signs and symptoms, I don't really need to tell you anything about that. I think we've gone over that in plenty of detail. But testing for Graves, at least from my end as an ear, nose, and throat doctor, it's pretty similar to what Dr. Cockerman talked about. The first thing I do is the basic blood panels to see what your thyroid activity is. I have a background where I'd done a lot of thyroid surgery. Kind of unusual. I'd trained both in oculoplastics, the specialty that Dr. Cockerman's in, and ear, nose, and throat. So I think I see two constellations of symptoms and two different types of patients in my experience, and I've brought that together, so I'm a little quicker to order certain blood tests and that sort of thing on some patients than maybe somebody who's just an ENT or only an ophthalmologist, and I'm not an ophthalmologist. Sometimes Graves is discovered by accident. It's not really from the symptoms that we've all talked about. I mean, those of you in this room, many of you are some of the worst cases that people in the spectrum of Graves will be, or as far as the symptoms that you suffer from. Sometimes I have patients who come in who just have an enlarged thyroid. They're a little edgy. We feel a lump. We get an ultrasound. We get a biopsy and blood work, and then you figure out that they have Graves, but it was very vague. So reasons to perform surgery on somebody with Graves' disease, there's lots of reasons. Hyperthyroidism or thyrotoxicosis, these periods where you're just uncontrollable heart rate, anxiety, and it's not responding to medical therapy. It's not a guarantee that your Graves is going to go into remission after you have a total thyroidectomy, but most of the time it does pretty well. In some cases where we've had rapidly worsening vision, thyroid eye disease, And it's not a good time to perform radioiodine ablation on that patient, even though they might have been a decent candidate otherwise. You just go to the OR and get it done. Everything comes with its own set of risks, but sometimes it's just a better option for you if you want to maintain your sight. Other things, and this is women interested in becoming pregnant. This is more in the spectrum of patients who have Graves but aren't suffering from all the symptoms. You're childbearing age, you're thinking about getting pregnant. A lot of practitioners would not give you radioiodine therapy before, certainly not during or even after. And so then you would become a candidate for surgery. If you have found a nodule in you and we know that you have Graves and or have a history of thyroid cancer in your family, you'd perform a biopsy, and if there was any question about the results of the biopsy, if it was even just a little bit gray, a lot of times you would go ahead and go forward with the thyroidectomy. And it doesn't have to be a total thyroidectomy if you're really just cutting your risks in half and finding out what that nodule is in your thyroid, even though you have Graves. You could continue to, maintain your own thyroid hormone levels and be treated medically. And then, suspicious thyroid nodules, the odds that you have cancer and a nodule in your thyroid gland are really low. They're really low. I have a thyroid nodule. I was training a bunch of residents how to do biopsies and ultrasounds. And I've got about a 1 centimeter lump in my thyroid, and that puts me in a group of about 30 or 40% of people walking around in the street. I mean, lots of people have it. And the odds that you got about a 5% shot that actually has something that would technically be called cancer in it. But it caught my attention. Everybody was making cracks about me getting my affairs in order and that sort of thing. And I gave them all poor performance ratings for that class. But not really. But so, like I said, I don't want to throw something else into the mix to give you guys more anxiety, but thyroid nodules in the context of Graves should be followed with an ultrasound. You don't have to have a CAT scan or radiation, and it should be biopsied. And the biopsy is something as simple as just, it's almost like getting a shot. It's done in the clinic most of the time, or at least in many people's clinics, they can do a biopsy with an ultrasound. Just do it by hand. You don't have to go into a surgical suite and be sedated and that sort of thing. Although some of my Graves patients are just at baseline a little bit anxious, so even something as simple as that gives them a little bit of stress. But it's getting a biopsy on your thyroid gland is essentially zero risk. It's just a little bit irritating and mildly painful. So if you, we're a Graves audience, so you do have some risk factors, but if your biopsy was just clearly negative, if you got several good samples, you can still just observe the nodule. You don't have to have surgery. Again, that's just the picture of an ultrasound handpiece. I've got one in my office, and I examine people's thyroids routinely. It's not a big deal. It's a pretty quick visit. I kind of already mentioned, what's a suspicious thyroid nodule, and somebody who doesn't have Graves or a history of thyroid cancer in their family. Something that's a centimeter or smaller, you could just watch it. But it depends. It's nobody would fault the surgeon or you for saying, it's okay, it's 8 millimeters. What does that mean versus 10 millimeters? Could we go ahead and perform surgery? And that's reasonable, but not in the context of a completely negative biopsy. Just for me, any nodule over a 0.5 centimeter in somebody for Graves is, should definitely be biopsied. And again, pretty low threshold for moving forward with a surgical intervention for that, at least on the one side of the thyroid. Because anatomically, your thyroid is sort of set up such that if you take out 1/2, you literally only have half the risks. There's zero risk that you'll have issues with calcium levels afterwards. There's a risk that one of the nerves that runs one side of your larynx and your voice could be injured permanently or temporarily. It's very rare to have a permanent injury, but you get the idea. So most of the time, the biggest risk I think for patients is just going under general anesthesia. as far as your actual life and limb is concerned. A little hoarse voice afterwards is not unusual. The incision is actually pretty small. There's a variety of different ways you can take out a thyroid. The thyroidectomy incision that goes from here to here doesn't really exist anymore, or at least not in trained ENT surgeons who are under the age of 45 or 50. You just don't need that much space to get a thyroid gland out. I've taken out thyroids that were literally the size of a football and extending into a person's chest, and so that was a pretty big incision. But for most people, it's pretty small. It's really only about 2 or 3 centimeters. There are some centers that will actually remove your thyroid through your armpit or axilla laparoscopically. That was pioneered in Asia and Japan. It's a big stigma to have a scar or an incision on your neck or your face. And that does, very infrequently, but it does in Asian patients or any patient of color, scar poorly. So that's an option. I think it's pretty laborious and your risks are a little higher. I usually don't bother with it, but that's something you could do. Bleeding afterwards, you're a lot more likely to have a problem with bleeding and having to go back in the OR to stop some sort of bleed than you are to have permanent issues with your voice or your vocal cord function. Nobody's asked yet, but if you completely knocked out one vocal cord, you still can talk, you still can breathe, you still can eat. You really only have to have one. There's about 5–10% of people walking around on the planet have one vocal cord. Doesn't really work very well at all anyways. If you lost your parathyroid glands completely, you basically would just be on calcium replacement for the rest of your life. Most of the time, the worst it is that you have to be on a lot of calcium supplementation for, say, several weeks or a few months. But typically, it's just a day or 2 in the hospital, monitor your calciums. If I was suspicious that I'd really beaten up the parathyroid glands that are stuck to the backside of the thyroid, or the regular thyroid gland to begin with. I mean, just a few weeks ago, I was taking out thyroid on one of our patients, and everything was just kind of, she was accelerating, everything was getting worse for her, eyes were getting worse, her anxiety was getting worse, she smokes a lot, and it took me 4.5 hours to get this thyroid out, and I was completely convinced that she was going to have calcium issues and her vocal cords weren't going to work. I walked out to the waiting room and told everybody that the vocal cords weren't going to work and her calcium was going to be a problem, would be in the hospital for, maybe a week. She was fine. She didn't have any of those issues, but she did have a bleed afterwards. And some poor neurosurgeon was walking by, and when she had that, he had to intervene, and that did land her in the hospital a few extra days. So, so the worst things that can happen to you, the vocal cord weakness, the calcium is actually probably about less than 1 or 2% in experienced hands. National average, world average, probably in the neighborhood of 3 to 6%. Any questions so far? Yes, ma'am.
I just was wondering, if you have the thyroid removed, are you going to have a weight problem after?
Not any more than you would if you had hypothyroidism already. Most patients, or at least, and I'm not an endocrinologist, but I do kind of get involved in thyroid hormone management sometimes, or at least I used to when I was working in a more rural setting, and there weren't specialists around all the time. But thyroid hormone replacement is pretty straightforward, I guess. You don't want an endocrinologist or somebody that really just treats you by the numbers. You have to kind of treat the person. What's their lifestyle like? Are they feeling depressed? Are they gaining weight? That sort of thing. But it's very effective. Hormone replacement is very effective, I think. There are some non-synthetic options that I'm not that familiar with. Dr. Chen was just telling me about it the other day, but we could ask him more about it later. This is a 2-centimeter thyroid incision. I mean, the entire thyroid, which is about twice that size, came out through that hole, but you don't have to make a huge hole to get to it. You make a hole, you get to one section of the thyroid freed up, another section, another section, another section, and you just kind of bring the whole thing out, sort of the way you might take out a gallbladder through a pinhole-sized incision these days. Usually, if it's the entire thyroid, I'm going to have you be in the hospital overnight for sure. You'll have a drain in your neck, which is tiny. I mean, it doesn't sound very attractive, but it's actually not that big a deal. And you heal pretty quickly. I mean, I don't know if you can see the incision on that lady's neck, but it's there. Right there. So, pretty much everybody you know, you don't really have to worry about incisions afterwards for the most part. So that's kind of the thyroid pitch in a nutshell. Yes.
Quick, just feedback on my experience with having a total thyroidectomy. There were no complications. It was totally straightforward. All the parathyroids were intact. You know, slight weakening of the vocal system for the first month, and then regained its strength after that. No bleeding, no anything. Big lifestyle change in not having to deal with that hyperthyroidism.
Yeah.
Real success.
Most of the time it is, you know, the patients are like, I'm so glad I got that thing out. This is great. But I'm kind of a conservative, sort of cautious guy, even though I do a lot of aggressive surgeries sometimes. So I you know, my preoperative talk with a patient's kind of like this. I tell you about all the horrible things that could go wrong, or at least the undesirable things. But most of the time it really goes well. And the parathyroid glands, it's not one or a group of glands all touching each other. There's 4 of them, and they're separated from one another. I mean, they have common blood supply, so you know, a couple of them gets roughed up. The other ones will usually be able to pick up the slack. And a lot of times, the vocal cord weakness that you have is as much swelling as anything else. When I am performing a thyroidectomy, and just about anybody that does thyroidectomies regularly, when you're doing this, the endotracheal tube that goes through your trachea and ventilates you and keeps you breathing actually has 2 little electrodes on it that touches the thyroid, or I'm sorry, the vocal cords. And I can monitor the electrical activity of the recurrent laryngeal nerve that innervates that during the surgery. That actually has not eliminated recurrent laryngeal nerve injuries that are permanent. It has decreased the incidence of temporary injuries. So people don't really use it as a crutch, but it is kind of the standard of care. There are some thyroid surgeons who, you know, do this stuff all the time, and they love to talk about how they don't need that thing, and really they don't. But now that the public knows it's available, you know, I don't think anybody would do it without it. So yes.
Oh, I just wanted to mention that we've got some issues of our latest newsletter on the table there, and the featured article is actually about thyroidectomy as a frontline treatment for Graves. Dr. Sippel out of Wisconsin came to us with a study they had done, and her point was, you know, it's not that this is for everybody, but it's one of the 3 options, and she wishes that all the 3 options would be discussed up front, whereas they're not always.
Yeah, I'm sorry, what was your question?
I was just going to confirm, for your patients with Graves disease, do you normally perform a total thyroidectomy? I
do. Because there's actually been no evidence to show that taking out like 95% of it is any safer for the patient. If you're operating on or being operated on by somebody who performs thyroidectomies regularly, your chances of having these permanent issues are very close to 0. It's like 1%, 2% or less. Now keep in mind that's about 1 in 100, but it's still very low. And yeah, most patients really do well. As kind of complicated a surgery as it can be in sort of tight space with important anatomy, it's successful. But specifically though for thyroid eye disease, I mean, what I do tell some patients is, and Dr. Cockrum should probably comment on this, is that it can help you with your hyperthyroidism, your thyrotoxicosis. It has not cured the autoimmune disease that contributes to the eye disease and a lot of the other things that go along with this, the symptoms, the systemic problems that patients have that aren't that well described. Kim?
Yeah, absolutely. So once the different battles have begun, they're on their own pace. So what's going on in the brain, what's going on in the eyes, what's going on in the precordial area, once they've been initiated, taking the thyroid out does not change that. The key reason we had spoken about this, the key reason that I refer to that, for thyroidectomy is because I see so many people doing this, which I know is doing bad things for their eyes. And so I'll see patients just progressing, and yet nobody's even, they don't even mention it. Never mind, it's not as the first line. It just doesn't even get brought up. I don't know why that's the case. It is a factor.
Yeah, I went through 2 years of methimazole, and with the TSI numbers staying up at 400, 450, where normal baseline is 100, And then after getting the thyroid taken out, a month later it was to 125. 2 months later it's at 95, 97, and it's just stayed there.
Yeah. And so, yeah, definitely one of the indications, and we see this more in the male patients, is if your TSI is greater than 250, you really need to go have the top of the surgery. And so that was when we were talking about who's a good candidate for prolonged, but then there's all not somebody where the TSI is prolonged high. High TSI gives you more prolonged brain dysfunction and more risk of visual dysfunction long term.
In the, you asked about the partial thyroidectomy. I mean, it's really kind of that's kind of between you and your surgeon. I mean, some patients try to kind of hedge their bets or mitigate their risks. There are surgeons who don't want to take out the entire thyroid because they don't want to be responsible for those the risks that go along with that. I mean, and for me, unless you tell me really request that, or you ask me not to take out the entire thyroid, it's all coming out as much as I have control over, anyways. Yes.
So, you were mentioning, the TSI level. But if you've had radioactive iodine and you have a high TSI, those are now two separate things going on?
Your TSI represents the circulating immune complexes that are available to attack your eyes, attack your brain, attack your
So I've got 522.
That's high.
Yeah, and it was, yeah. So, but I had the radioactive, so it's not a factor around the thyroid at this point. It's just the circulating.
Right, this is the circulating. And radioactive iodine without IV steroids, it typically is not going to improve your TSI. A thyroidectomy will. Radioactive iodine plus the IV steroid protocol can. But the most effective way to get the TSI bumped way down is to do thyroidectomy.
Yeah, I mean, a sort of non-functioning thyroid is still thyroid tissue. You still have thyroid receptors there, and I don't know.
So if you still have a thyroid in there, it could still be causing the TSI to go high?
I think so. I mean, I haven't done those studies myself, but I'm just telling you, I go in there that looks like a thyroid, must be acting like a thyroid because it's got something that your body's immune system is interested in, and so it keeps producing those antibodies.
Yeah. So how we were talking about, so the TSI reflects those serum immune complexes. Those are not ablated at all by radioactive iodine. That, as Chase was saying, that thyroid being there, it still has those little receptors there. All it does is ablate the function. Yeah. It doesn't ablate the receptor.
You're just not hyper anymore, but you still have this active disease.
Can I ask, is there any way to turn the air conditioning down a little?
Oh yeah.
What else is cold?
You can take my jacket, man. I'm sweating up here. It's the pressure of talking in front of all these pros. Who remembers who this guy is?
Marty Feldman.
Yeah, I put it there just because I didn't want to forget anyone. This Marty Feldman is an actor, or was an actor and comedian. He's passed away, but that's his identity. Everybody remember his name, and
I remember Igor.
Yep. But he went by Igor. It wasn't Igor. It was Igor. This picture is actually kind of inspired by my mom. Grew up a kind of a latchkey kid, single parent. My mom was working all the time. In the 80s, you had the only thing she would allow me to watch was PBS and Mel Brooks movies. And so I saw a lot of Marty, but later on, my mom was diagnosed with, and none of this has anything to do with my choice in career. I always wanted to have my own fishing show, but she was diagnosed with thyroid disease, and later on it was discovered that it was Graves. But this is Texas, and we don't mess with stuff, and we just cut it out. She had a thyroid issue, and it was gone like that. So she never really progressed to have all these issues. But we always used to watch these movies together. And being a woman working in the South in like 1984, trying to raise two kids, you could imagine what her concerns might have been had she started to develop a lot of proptosis and exophthalmos and double vision and that sort of thing, because she was it. I mean, nobody else was taking care of us. And she had to, maintain her lifestyle as a working professional So that, I don't know, I always thought about that. But yeah, later on I had other interests and other careers, and even in medical school I was going to go into something else besides this, but I was just looking at his photograph earlier today. But like I said, that's his identity. This is not your identity. Anybody else here a stand-up comic? Anybody else going to, starring in any slapstick movies anytime soon? I don't think so. So, it's important that this sort of thing be taken care of for patients. First, for their vision. I mean, you want to, I can't stress enough that, all of this, even though cosmetically you do improve, you need to think of these things as functionally essential procedures first. Because don't worry, we're not going to forget about you, okay? We've done your first decompression. We know your one eyelid's going to be over here and this eye's over here, and you'll be with Kim and I for a long time. So, but in any case, I already kind of talked about how what the pathophysiology is, or the explanation is behind your eyes sticking out and the vision going bad. But how do you go from the top photograph to the bottom photograph? And so, and I'll just kind of talk to you a little bit about what the approaches are, what the risks are, and you'll get more information when you ask questions from me. But so I'm ENT and skull-based, but I also do these external surgeries. Kim and I team up a lot on cases. I go in through the nose, essentially perform a sinus surgery, clear a pathway to the orbit, and I take down bone from the inner wall of the eye socket or the orbit and open that up and allow a lot of the fat and contents to herniate into there, creating more room and space for the optic nerve. And then there's the external approach, which is either done later, depending on how bad their disease is, or at the same time. Involves an incision at the corner of the eye. You remove bone from the outer wall of the eye and decompress things that way. Both approach. In some of your research or some of your interaction with different doctors, people may have told you the only way to do a decompression is externally and taking down all three walls of the orbit, three walls being the outer, the inferior, and then the inner. I'm taking down the inner when I go in through the nose. You can take down the inner going externally, but the healing time's a little bit longer, and generally speaking, and a lot of patients just like the idea of one less incision somewhere on the outside of their face. But like I mentioned, you need to look at this as surgical treatment to save or restore your vision. It's a medical necessity. If you think of it only along the lines of cosmetics first, you may be a little bit disappointed or taken back in the beginning once you start having these procedures performed on you. Anybody having had decompression procedures have any comments about that so far? Not yet? Okay. And additional corrective surgeries a lot of times are required. Sometimes eyelids retract up, sometimes they're a little droopy. I've got one pretty good example of that a little bit later. And typically this is an outpatient procedure depending on your age and your health. I don't know, some patients we send home, some patients we keep overnight. Kim, it's a mixed bag. This is not a Graves patient, but she let me use her photo, so I threw that in there. But the dotted line is basically the sinus approach. These are the kind of three general approaches to the orbit. Through the nose, there's a transbleph incision, what we all think of maybe as an eyelid tuck, an incision up here. You can make an incision there, remove a lot of orbital fat. That's not a decompression exactly in that you're removing bone, but you can remove fat to make more room. And then this lateral incision here on the edge actually heals really well, but you can create a lot of room, get to the outside wall of the orbit, take bone away, and allow those contents to herniate out into this soft space here. And so just to kind of point out, these are, never mind all the fine points of the bony anatomy here, but the outer wall is generally this area here. So that corner of the eye incision, you're going for the bone here. Open up a, maybe 2 nickel size, quarter size area of bone to allow the contents of the orbit to herniate. This ethmoid bone here, so this is essentially a close-up shot of that right eye socket. This bone from here all the way to the front to where the lacrimal duct is, your tear duct, that's the bone that I'm taking down, including some of the bone that's down here in the floor of your eye socket here. this space here is where your orbital or your optic nerve is, that you need to see, the thing we're trying to salvage. Usually I'm not really getting near that, but technically speaking, that's at risk. Some of you have had decompression procedures. Mentioned something about somebody saying, do you really want to do that? You're going to go blind. The odds that you're going to go blind, at least in the literature that I'm familiar with and in my experience and my old mentors, is basically zero. Kim? Zero. It's almost non-existent. People used to go blind from orbital surgery a while ago when they could not monitor them very well, when they didn't have ER services or emergency services, and they just bled into their orbit and it would choke off the blood supply to their eye, and that's how they lost it. I've never actually seen or heard of anybody having that happen in modern times, but whatever that means. So the endoscopic decompression, I describe this basically as like just kind of an extended or advanced sinus surgery. You've all are probably familiar with sinus surgery. There's an endoscope. I'm not physically looking through it with my eye like this. It's up on a monitor, and I'm doing my work and watching what I'm doing. But these areas, there are cells around the eyes that I take down, and I expose that inner wall of the eye socket, and that's where I make my window. And your recovery from this is essentially just like the recovery from sinus surgery, although it has a few extra risks. Again, so this shot here, these are called ethmoid cells. When I go in through the nose and I try to get to that inner wall of the eye, I take those down. So here's the inner wall of the eye and that bone, and that's what I'm removing. A lot of patients, especially in Northern California, have allergies that go along with this, and usually they're pretty stoked with the results of that afterwards. So here's an intact medial wall of the orbit right here. A little bit further back in the orbital cone, but it's very crowded there. And so this is the absent bone. There's not a white wall that you can see. This is one of the rectus muscles of the eye, and it's actually kind of herniating over into the cavity, but that's to be expected. Now, the contents of your eyes are not like exposed in the nasal cavity for the rest of your life. It actually covers up with mucosa normally, and you don't have some communication between your nose and your eyeball. And that's really, I mean, if you had any other, I could go on, but really I'm just kind of telling you about what it's like to have sinus surgery. And I'll mention a couple of the other risks with that one here in a little bit. So external decompression, this is an incision, so no incision here. This is the incision about 8-9 days after surgery for an external decompression. Even in this patient who's Indian, generally those incisions on those patients are going to be dark and more noticeable in the first few weeks, and it's difficult to see. I mean, this is not like a pitch or a guarantee, but usually people heal very rapidly. Yes?
Is the scarring above the eye?
Oh, he asked me to fix a scar on his eyebrow. See this little depression right here? Yeah. I knew somebody was going to ask about that, like, why is there a second hole? I didn't put a second hole in this guy's head for the decompression. So, in any case, but that's a reasonable expectation. And again, this is not for cosmesis or aesthetics primarily, but people do want to know what they're going to look like and what their healing is going to look like. Now, at day 3 or 4 or 5, he doesn't look like this. Right, Bob? No. I saw you, what was it, like 4 or 5 days after your first surgery, you come in, you got the tape all over your face, and you're like, I can barely see your eyes. You're like, is this normal? I'm like, yeah, absolutely.
They had 2 stitches right on the side holding my eyes closed.
Yeah, you couldn't see much of anything, but it's, we see those patients afterwards, and it's kind of old hat to us, but when you're the patient and it's about 3 to 5 days after surgery, that's usually when you look your worst and usually when you have the most questions. But this red line basically, or at least on CT scan, I just want to point out a couple of things. This red line just kind of indicates like how far back an eyeball can move and how much more relaxed the optic nerve can be. But you see, it doesn't change the quality or the size of the rectus muscles. They're still really big. So, this is the lateral wall of the orbit. there's no more bone there. Everything is still structurally sound because this arc of bone is attached to your forehead and attached to your cheekbone. You don't really need that lateral wall. Yes?
In the picture, how many millimeters is that attachment?
How many? I don't know. I was just kind of ballparking it. That's probably about 4 or 5 millimeters. When you, or at least when we read studies about what other people are saying about their decompressions, I don't, at least I tend not to measure people in how many millimeters their eyes move back. People will say you do 1 wall or 2 walls, you can get anywhere from 3 to 5 millimeters. Some say 2 to 4. What matters is how your eyes function when we're done. But there's a lot of studies and stuff out there, and basically kind of I got 6 millimeters out of my procedure, so I'm awesome. But was their vision any better? Maybe not. Kim?
Yeah, it has to do with your appearance, and as we're doing it, we're looking at your 2 eyes. Healing now is saying you feel firmness.
Yeah.
So it's really titrated specifically to the patient.
Yeah,
a lot of decisions about how much bone or how much fat are decided right now on the table.
Yeah. So. I don't know why I bring this up exactly, but there's not exactly an age limit on this. When I first started practice out here in California, the average age of my decompressions, thanks to Kim, was 88 years old. I think my first 4 or 5 patients with her were, remember the Chinese lady called me from the hospital, like, we got to go right now. And then, I did the surgery and she disappeared on me for a while, but there's an after photo I'm going to show you here. So risk factors of these decompression procedures, a CSF leak when you're doing it, particularly with the endoscopic or the extended sinus case version of all this, a CSF leak is a leakage of the clear fluid that surrounds your brain through the roof of your nasal cavity into your nose. Doesn't sound that great, actually happens really infrequently. When I have had it happen, it's happened enough, which has been like maybe 5 or 6 times, that you don't get too excited. Those things actually heal fairly rapidly when you create them yourself. There are people who are born with these defects and they leak no matter what. Those never heal on their own. But this is something to be aware of. That is a risk factor. And theoretically, meningitis is also a risk factor, although I've never really seen it. But you're on a lot of antibiotics before and after surgery anyways. So that's, you can have some headaches from that. It can affect your vision if it was a high flow leak. If I see a high flow leak during the procedure, then we're going to patch it up then. Otherwise, we just, I put a little packing in and it dissolves and it heals up on its own. Diplopia or double vision, oftentimes this, like some of you were saying, you have seen a lot of doctors. You're going to see a lot of doctors, or in your journey, you may see a lot of doctors who say, well, you don't want to do a decompression, it's not practical because you'll have double vision. So maybe your vision's better, but then you're going to see 2. A lot of patients really have double vision already. They just may not really be well aware of it, and they're going to have it no matter what we do in surgery, whether we do surgery or we don't do surgery. So I mentioned that as a risk, but a lot of times it's just an expected sort of second phase. And that's where Dr. Cockrum comes in. Bleeding, infection, just standard stuff. And then eyelid retraction or drooping, especially if you take a transblef, you make an incision in the upper eyelid to remove as much fat as you can in severe cases. Those cases, they can have a droopy eyelid afterwards, like that. But after probably 3 or 4 more surgeries and some laser work for her skin and some Botox, she really turned a corner, but you could hardly believe that that's actually the same person. This is a fairly early post-op picture. This is about 2 to 3 weeks, but this ptosis or this droopiness, that remains, and that's just a byproduct for surgery. But her vision was salvaged. So other little things, kind of long-term eyelid retraction, or in some of my patients, I operate on a lot of Asian patients. That's also just sort of part of my subspecialty. But many of them will kind of lose the shape or quality of their crease. And even non-Asian patients will come in saying, I feel like I've got more skin on one side afterwards, or this eyelid is really hiked up. And it usually takes secondary procedures to fix all that. So, thank you.